Welcome back to our Unclenched podcast. Today we'll be speaking to author and Dr. Robert Kerstein. I met Dr. Robert years ago at a class in Texas that I took on DTR. But before we bring him on, I got to get caught up with Priya. What's going on, Priya? What's happening in your life?
Yeah, just busy with family stuff. My kids are 6 and 8, so I'm in a little bit of a different stage of life than you. I think your kids are a little bit older. So everything is consumed by the kiddos, and I wouldn't have it any other way. So my son is in kindergarten, my daughter's in second grade, and they just bring us so much joy. And they get along really well with each other. I found out recently from the teacher, like a few different teachers and the principal, that my son and daughter are like, every time they see each other in school, they hug each other. And my daughter is like so nurturing and so loving to him and always like wants to play with him. They share one recess. And I just thought that was so cute and sweet.
Big brother.
Yeah. So my whole life is like them, and I can't wait to get home from work. And, to be honest, there was this a phase where I kind of like dreaded going home. Like I'd take the long way home because of the tantrums and you know what I'm talking about, and the craziness.
Oh, I know.
Yeah. And they're older, right? So they've outgrown that. And they're just such a joy and fun to be around. And yeah, what's going on with you? And tell me about you, and then also a patient that's been on your mind.
Yeah, sure. Well, with me, wouldn't you know it, last night I spent the day in the hospital. The girls from work had to drive me to the emergency room because I had a kidney stone. So it was god awful, but thank God I passed it after.
Have you ever had one before?
Yes, I had one in May. That's a long story. I was in the hospital for then too, and I was supposed to go get tests, and I'm like, I'm okay. But they said nuts can cause them, and I eat a ton of nuts.
Me too. I didn't know that. Is it because of the salt?
It could be because they said salt and nuts. So I'm like, okay, my nuts are salty, so I'm kind of screwed either way I go.
Salty?
So yeah.
Sorry.
So I So it was a bad day, but here I am today, back in the saddle, and it's all good.
Salt. Now I'm scared.
Well,
I'm glad you're okay.
Here. But you're a little bit younger than me too, so you got a ways to go. But they may come get you later in life.
I love that
because I never had them before either.
Tell me about a patient that's been on your mind.
What's been going on with you? Oh, well, you asked me about a patient, so let me tell you about a patient of mine. This patient I want to talk about is Ashley. So Ashley is a T-scan patient, and that's what we're going to be talking to Dr. Robert about. And she had terrible ear ringing. It was driving her crazy. Mm-hmm. She couldn't sleep. She was a clencher. She was a grinder. Also jaw pain, a lot of tiredness, like in her facial muscles. And she first called Ben Sutter to find out, what to do.
Where does she live?
She lives, she's about an hour away from me.
Okay.
She's pretty close. And so Ben said to come to me, and she was very apprehensive. So all the time during treatment, she would call Ben and I wouldn't know, but then Ben let me know, hey, she called. But she'd call Ben and say, is this right? Is this, blah, 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 blah. And he's like, It's right. But we saw her this past week, and she's doing tremendously well. She's so thrilled. But now that her ear ringing is down, she said, when my daughter talks to me, it sounds like really loud. I said, well, that's because the ear ringing's not there anywhere to muffle her noise. But, so she's like, I feel like I have canine hearing, like I can hear anything now. But so she was a great thing. But that was a Ben referral. So appreciate you, Ben, if you're out there listening.
Yeah, I love Ben. Well, what were some of her symptoms? Sorry to
so her symptoms were her terrible ear ringing. That was her main thing that was driving her crazy.
Okay.
She was also a clencher, grinder, and jaw pain, tiredness. That was about it. Some facial pain and I don't think she had ear pain, but there was something else with her ear. I can't remember quite off the bat, but she's doing well now, and that's all that matters. And it was all because of the T-scan.
Oh yeah, totally. Well, I actually have a T-scan patient to share with you too.
Uh-huh.
So her name is Jordan, and she's a dental assistant. So really interesting. So she came to see us with jaw pain and swelling, and I'm reading her symptoms off. That's why I'm like looking down. Limited range of motion, tooth pain and sensitivity. Her bite felt really off since she had a tooth pulled. She had a stuffy right ear, ear pain that was sharp on her right side, pain with chewing, neck and shoulder pain, and headaches. So a lot of pain, right? And I when I first started seeing her, I didn't know anything about DTR, Disclusion Time Reduction Therapy, which is what we're going to be talking about for this whole podcast. So I put her in an orthotic, a day one and a night one, and her symptoms maybe got like 50% better, 50, 60, right? But she would have these flare-ups that would just come on, and her pain would go right back to the same level, and then it would die down. So I was like, and she would tell me periodically, it's my bite, it's my bite, it's my bite. But you and I talk about like, you only know what you know. And I just didn't have the knowledge that I have now. So finally, when I started my certification process for getting DTR certified and using the T-scan, I just kept going back to her. I was like, it's her bite. She keeps telling me it's her bite. And now I understand it's her bite. So I said, why don't you stop wearing the orthotics for like a week? And then let's check your bite with the T-scan and the DTR. And yeah, it was her bite. Her bite was so heavy on her left side. So once we started working with her bite, she had like weeks on end with no pain. And I had never gotten her to 0%. And I thought, oh my God. But the thing is, it would come back because once it was always tooth 15, the upper left, like last molar there. And Dr. Sutter always says a compressed tooth will continue to erupt until it's not compressed anymore. Right. So we'd like remove a little bit of tooth structure, barely any microns, and she would feel really good. But then the tooth would erupt more. So she'd rebound and her symptoms would rebound a little. So we'd do a little more and then her symptoms would rebound. So I think she's coming in for maybe her fourth DTR pretty soon because she's been feeling good for like a few months now. And then she texted me and said, hey, it's like kind of starting to come back. And she's waiting to go into ortho. And I'm like, don't do ortho until your pain has been gone for like months, right? 3-4 months at least. And so anyways, that was a really great success story. But yeah, so I mean, I think that it's time to get Dr. Robert on because you know me, I can just talk forever.
Yeah. So I'd like to introduce Dr. Robert Kerstein. He's been a mentor to me and to Priya in the T-scan department and DTR. And Robert is a pioneer and an academic science advocate for digital occlusion technology. And he's recognized as a leader, author, and researcher in the field. Dr. Robert? There he comes.
Thank you for having me. Hello, ladies. Thank you for having me.
You're so welcome.
Yeah, thank you.
Nice to see you all. It's my pleasure. It's my pleasure. I enjoyed listening to your stories about your patients and how they were helped with the T-scan and the DTR
and all because
treatment.
of you and Ben, and just you're always being there for us when we have questions or concerns, and it's just we so appreciate you.
Yeah, you're just so kind and generous with your time. Like we just met and like in Vegas recently for the course, and you've already helped me with patients. We've talked about a specific patient together, and you're so great. So the reason we're having you on is because not only do we love you, but you have taught us both so much.
I'm very lucky. Well, I'm very lucky to be on, but you're both learning and experiencing the benefits of obviously using digital occlusion technology. And anyone who learns from me, I'm always available.
I know, you're
to help
so
them.
lovely.
So,
and I've gone to other courses. I won't name names, but you can't even ever talk to those doctors. They're so untouchable. And as soon as they lecture, they're gone forever. You never see them again. So thank you for being available. And, you've taught us both so much about Disclusion Time Reduction Therapy, DTR therapy. So can you explain to our listeners, many of who are TMJ sufferers, what DTR therapy is?
Yeah, so I'll give you like a basic explanation, and then I can show you an example, which would really illustrate the benefits of it. So disclusion time reduction is a a treatment that controls the amount of muscle activity that comes from the teeth. And the teeth are making muscle activity all the time just by someone using them, just by chewing and eating and swallowing. And people that suffer from that get symptoms. Many people, their teeth don't operate well and they don't get symptoms, but DTR treats the TMJ muscular symptom group by controlling the amount of muscle activity that is produced by the teeth. And this is why you might, for example, you were talking about a patient that responded pretty well to her two orthotics, but her symptoms would come back. And despite her being probably very religious about wearing the orthotics, because she can't use them to chew, eat, and swallow. She has to take them out and her teeth would come back together again. And then the other piece of that she talked about, how it took her a while to get comfortable with one or two teeth that kept rebounding. The bite changes have to go on over several months so that the human being sort of stabilizes and achieves a state of low muscle firing. And the teeth will keep kicking it up on some level until that sort of homeostasis is reached. And that's a combination of them healing, the procedure, removing the muscle activity, and then changes to their bite that go on because they're healing and their teeth are changing in the socket. Like you were talking about this, tooth, like what Dr. Ben said about the tooth, slowly coming out of the socket. So the treatment itself is rendered over a series of appointments, and it's rendered with the T-scan. But I can show you an example. So here's an example of a patient who's about to make a left movement from a clenched position where they're in MIP. And when you look in the black box, you can see there's dense muscle activity in the two temporalis, especially the left temporalis, and less dense muscle activity in the masses, but still apparent muscle activity. And this is before they undergo DTR treatment. And what you're going to see is when they make a left movement, that their posterior teeth here in the T-scan aren't going to come apart. And the center of force is going to travel towards the posterior teeth. And that's going to keep muscle activity levels that you see in this bar graph up. So watch what I mean. Patient's going to go left, and you can see up through here, this is where they're now going left, and there's muscle activity. The temporalis is going to keep going back and forth and back and forth. You see over here the group function on the T-scan data with one balancing contact. It's the group function that's raising the muscle activity. And now as the group function begins to dissipate in the T-scan, the muscle activity starts to go down. And this is with long disclusion time. So the disclusion time here before treatment is 9/10 of a second to make that movement that you watched and reach front teeth with this very low muscle activity. Then after treatment, which is here, same day, if you look at the black box, again, you see there's a lot less muscle activity, both in the clenching period, which is here, and in the making the left movement period. And what's interesting is the signature is the same. There's still a group function, which you'll see. I'm going to play this now. The group function is much shorter in time, but while there's group function, which is what's happening, you see the center of force goes close to the 2.6, and then you see the posterior teeth starting to drop in the T-scan. As the posterior teeth drop, the muscle activity levels drop. The difference is in the time it took to do that. And the new disclusion time is 0.46 seconds. So what's really going on is the amount of time the back teeth are rubbing together during that working side group function is far less, and the muscle activity the person makes is extremely less. And you can see that clearly here. So here you have the preoperative condition. There's the left orange quadrant in the graph is the group function. You see in the black box the dense muscle activity. And during the excursion, which is where we are now, while the working side group function is on, there's high muscle firing. After treatment, you see the same signature in the way the muscles look, but there's definitely less muscle activity. There's still a group function, but it's much smaller in time and much less forceful. And the big difference is in the disclusion times. This is 0.95 seconds, makes this very high muscle activity. 0.46 seconds makes very little muscle activity. And this is how the physiology works. The T-scan EMG then measures and removes the muscle activity because the disclusion time has been markedly changed. Now, you asked how the T-scan measures or gathers this information from the patient. So essentially, the T-scan is a USB connected handle to this sensor, which then transmits force and timing information from the patient biting and compressing it, chewing over it, grinding on it. You can record a number of different things with it. I just showed you how to have the patient make a left excursion across it. And when that happens, 2,200 electronic force measures are activated and streamed through the handle to a USB connection that transmits the stream to the desktop. And that's why you get a dynamic video of the occlusion, although here is a static image. And on the desktop, you have a number of software features that allows you to analyze both static or MIP and dynamic occlusion, which is making excursions or chewing, clenching, and grinding on the sensor. And you get outputs in a color coding that allows you to grade forces. So it's actually very, in its own way, simple to use. Here's moderately low force. Here's moderate force. This is higher force, slightly higher even more, and then very high forces in pink. So if I wanted to adjust the high forces in this scan that it's in the patient's MIP, I would take this pink column and come over here to the palatal cusp of this left first molar. Or if I was going to work on the posterior right, I would be looking at the mesial marginal ridge of the right second molar. That's where these contacts are. So you use the color coding and the mapping to be able to create intelligent decisions about what to record. And the data illustrates how to make a very targeted decisions about what to treat or what to not treat. For example, what's low force versus what's high force. And what that allows you to do is to record from patients many different things. So I'm going to just show you again how the T-scan and the EMG record on a patient. This is a post-orthodontic patient who has jaw problems, jaw tension, gum recession, has headaches, frequent headaches. And this is exactly the kind of patient the T-scan EMG allows you to gain information on. So here you can see I'm going to record this excursion. And there's some background noise. So this is the T-scan here. This is the EMG. Watch how the patient bites down, the data comes up. You see I'm now recording. She's biting, and now she's going to slide to the right. And at the same time, the EMG is being recorded.
She has premolar guidance. She has, she does reach her canine, but she has premolar guidance going to the right. Okay.
So I can observe the entire recording and understand what's happening because it's real time. It happens exactly as she does it in the mouth, which is a great advantage in terms of being able to judge the occlusion. And then from there, you can use the T-scan EMG data in order to understand the patient's occlusal physiology and what kind of muscle problems they have and why their teeth are making so much muscle activity. The data you can gather can be used in many ways. And it can be used to diagnose a TMJ problem, like what we've been talking about, but it can also be used on prosthetic dentistry, implant dentistry. It can be used in finishing orthodontic patients, and you can then improve those outcomes. And how you get the data is essentially directly from the patient. So, and you can watch it. The beauty of the T-scan is you see it happening, and that's how you know that it's a good recording. So here the patient's going to bite down, and I'm giving her instructions, and you can see the data form, and then we can go back and analyze that. And we can analyze it with the EMG, which is, really a fantastic combination. And that's really how we treat the patients. So hopefully that gives you a good overview.
Yeah. It's amazing. And I've got to tell you, I've been using this, and I've been using the T-scan for probably 8 years, maybe 10. But I've been using
I didn't know that.
Yeah, I've had it for a long time. But I've just been using it by the training you get from T-scan when they link into your computer. So 2 years ago, though, was when I got certified and I had Ben and Robert out to my office. Now I really know how to use the T-scan, because before I was just trying to get an even balance after my ortho, which was good, and patients were fine, but it wasn't great. And now I utilize it to its full, I think, effectiveness. And it's been great with my patients, and I don't use it on every patient. I use it on, I take that back. I use it on every patient, but sometimes it's on the patient with orthotics. So it's not just a
Yes.
DTR
Yeah.
patient. So DTR patient, you have to have certain criteria to meet to get
To
the
be a
DTR.
candidate.
Like if your jaws are or your joints are sawed off, obviously I don't use the DTR, but I'll build my orthotic, then I will use it, for
Sure.
that.
Yes.
So it's really helped me kind of like get the patient better quicker. Like if they're in an orthotic, because I'm using it with every orthotic.
Sure.
So I'm like, okay, I can see the spots better, and every spot is not need adjusted, or the big spots aren't the one to go to first. I listen to my T-scan.
Well, that using it with your orthotics is just another example of how case finishing with force, pressure, and timing metrics greatly improves the efficacy of what we make.
Absolutely.
So, an orthotic, right? So that's the benefit that you're seeing with
and
that.
I use it for all my full mouth cases, every full mouth case.
Yeah.
And I use it with all of my post-ortho cases. Every one.
Nice.
I balance
Yes.
for ortho.
Nice.
So I'm using it.
Oh, I'm using it too. Like,
Yes.
I got certified in, October of last year. So I've just been certified for a few months. And since being certified, I actually got a second handle to use in my new patient exam room. Because as soon as I think there's a DTR candidate, I get their scans right away. And so there are some who are clearly not great candidates. Like, yeah. So I don't get the handle out right away. But if I think that they are and they would benefit from DTR, then I can take some recordings and show them. And like showing them the data is powerful. Like looking at your bite force, your own mouth is powerful. And once I explained that, like the articulating paper that we were taught to use in dental school, you bite down, you think bite force, we're taught that bite, like the size of the mark of the paper correlates to the force. That's what we're taught in dental school. And once I educate them that that's actually not the case, like even a very small mark can be a powerful bite force, right? Once they start to realize that, and they're like, oh my God, yeah, like my bite is really heavy on the left. That's why I always chew on the right. Like I just had a patient the other day that said that. And so once you start to educate them and showing people these readings that we're getting, it's just so powerful. And I feel like being DTR certified, having the T-scan has been a really powerful practice builder. And the associate that I'm bringing on, I'm going to make sure he gets certified too, because it's so powerful. So,
well, Dr. Robert, can you please let everybody know, because you're so accomplished in so many things, like what's your dental background? How many years have you been practicing? And I know you're retired now from your dental practice, but tell us about your background.
Well, I was planning on being a dentist when I was in high school. I didn't really have the grades to be a doctor. I was never the really great student. So I figured dentistry, I might be able to get into dental school. So I managed to be a B+ college scientist student, and then I went to Tufts Dental School, and I actually thought I was going to become a prosthodontist that just went out and drilled a lot of teeth and made a lot of crowns. And back in the 1980s, it was really the golden age of metal ceramics and gold in dentistry, and all ceramic dentistry wasn't really, it was evolving. It was sort of like a lot of things were being tested, different kind of ceramic systems, but they all broke and failed. And so it was a big emphasis on metal ceramics. But while I was in prosthodontics, which was after dental school, the T-scan 1 was built, and that was 1984. Wow. And we had it because the person who built it was my teacher.
Oh, you didn't build it?
Engineer from. No. I was exposed to it along with, actually, the prototypes were given to 16 prosthodontic departments around the United States, and they were, sort of handed out for people to try to experiment with and use them. And my teacher was actually the person who built it, Dr. William Mannis, and then 5 engineers from Massachusetts Institute of Technology. But the collaborating teams were from BU and Tufts and MIT. Wow. Those were the 3 universities. And unfortunately for the T-scan, no one really took to it. And we didn't have computers at the time. The first two computers in dentistry were CEREC and T-Scan 1. They were built at the same time, the first CEREC. And everybody maligned them both. CEREC, everybody was like, no, a computer can't make a better crown than a human artist who's a ceramic, expert from, Switzerland. There's no way. And no one really liked the T-Scan either. And people wrote a lot of papers about it not being good and the sensor not operating. And, it was generation 1. But when I would use it and try to figure things out with it, it sped up treatment. So I started to study it. For example, speeding up treatment, I'd make, a full arch of temporary crowns, and the patient I didn't use it on would come back and say, my bite's off on one side and it doesn't feel right. And, whatever the typical bite complaints are that we all deal with. And then I would take the T-scan and fix it up. And when they came back for their next, session in the prosthodontic, sequence of events, they were like, yeah, you straightened it all out. And then when I would use it on people that had headaches and jaw pain, I would be able to, ease that off for them. So I began to study the T-scan and prosthodontic education. I can't speak for other programs, but postgraduate education, they make you into a scientist. You have to stand up in front of the room and tell everyone why you chose to do 3 crowns on the left and 4 on the right, and what was the reason you have to have a scientific rationale for why you use this cement versus that cement, and you have to cite literature. You have to cite, so-and-so showed that the compressive strength of zinc phosphate is this, and, it's not going to work in this situation because the span is too long. You had to be able to say those things. And it was nothing that I expected, to be honest with you. I was kind of thrown into it. And when you didn't do well, it was a bloodbath. I mean, the faculty would, they would tear you up. And we used to call the case presentation seminar the bloodbath seminar, but that's another story. So it made me into a researcher, and I kept studying the T-scan because I found things it did that other people couldn't do, like treat headaches without an appliance, right? Or stop people from clenching and grinding. And that's when I started to realize the disclusion time was very important. I discovered the disclusion time in like 1987. And then I started to write about that and study that. And it changed my whole career because I really didn't become a high-powered prosthodontist crowning all kinds of teeth. My practice sort of was split between bite problems and prosthodontics, and then it evolved into treating TMD problems with T-Scan EMG, which I helped evolve, and TechScan and BioResearch together, they collaborated. And some of the people that I worked with at both companies, they made the T-Scan EMG, and then you could really see the implications of the bite in the physiology. And both products became much more refined. T-Scan 7 was much better than T-Scan 2, and T-Scan 10 is much better than T-Scan 7. So we had an incredible technological evolution, and it changed what I did. I became an academic more so than a clinician, and I spent my time teaching and lecturing and traveling. And I didn't develop a huge business model. I'm not the best example of how to run a high-powered prosthodontic practice, but my life, I mean, I've been very fortunate. I've seen so many countries. I've lectured in parts of the world I would never see. And I've been fortunate to meet dentists like the both of you who take a serious interest in using technology for this specific thing. There's a lot of resistance to using bite technology in our profession. And so I'm grateful for, both of you for being, focused on moving forward with this kind of amazing technology. It's 40 years now that it's evolved, and it really helps people, as you're finding out.
Wow.
Well, one thing too I want to make clear is that Dr. Robert he's not trained like Dr. Alex and myself. Dr. Alex and I would definitely call ourselves neuromuscular dentists. And I don't think Dr. Robert would go out of his way to say that about himself. So are you more into centric relation or centric occlusion? And can you explain what your occlusal, how the teeth come together, what your bite philosophy is?
Well, it's a very good question. So my prosthodontic education was really focused on CR, which was at the time, you may have heard these terms, Pankey-Man-Schuyler philosophy.
Yes.
That was the CR-based philosophy with, you've heard of it, with an anterior guidance aspect to it. But the main thing was to find CR. And the belief was that CR was going to solve your problems. If you put the person in CR, muscles would relax and symptoms would go away. And of course, none of that is true. It's never been proven. And no jaw position, whether it's CR, MIP, or neuromuscularly found, can totally control the occlusion, because the teeth actually drive all of the problems that we face, and they don't really know the jaw position. One time I had an audience with Pete Dawson, and I showed him the T-scan EMG at the time, and he didn't accept that when he put the person in CR, that their teeth, when they hit, they made muscle activity. And he goes, that can't be right. The technologies must be wrong. So I said to him, I said this exact thing. I said, Pete, the teeth don't know they're in CR. They make muscle activity every time they strike. And he did it 4 times, and he still had a hard time believing it, because the philosophies, some of what they advocate, and I can't speak that much about neuromuscular because I don't know it as well, but the ideas behind, let's say, a single jaw position solving the problem,
it's not possible. It doesn't make sense. We're all individual.
And the teeth play a huge role that is way beyond the jaw position. So you can open the bite and move the mandible, but the teeth, if they don't operate well at that new place, they still cause
the muscles,
problems.
The nerves, I think CR also, the problem with that, and CR stands again for centric relation, is that the definition has changed so much over time, right? So for a while it was posterior superior, then it was anterior superior. I think now it's anterior superior again, but it's an arbitrary position designated by dentists trying to just make a rule for something, but that's not how the body works necessarily. So anyways, yeah.
Well, the CR belief system was very much disproved by the T-scan. And that was one of the great controversies at the time, that I was writing about working in MIP. All of the studies that we've done, all of the papers that have been written by the DTR researchers, myself and others around the world, they're all performed in MIP. There's no moving the mandible, right? So people like Dr. Dawson, he didn't like that I was putting MIP in front of CR. And the neuromuscular dentist didn't like that I wasn't moving the mandible and finding the myobite. And I didn't need to do either one. So I became a CO clinician, even though I was highly educated in CR. And I treated most things in CO, and that was much simpler for me and much simpler for the patient. And I think you're also finding that as dentists, that if you don't have to move the mandible and re-occlude all the teeth, and you can kind of do that pretty well in a number of ways, but you still have to control the occlusion at the end. So I found I could manage a lot of TMJ patients just in MIP and treat them without an appliance or an orthotic. And that became how I developed my practice. And that was all from working with the T-scan.
Wow. So you're retired from practice now, but I'm just curious, how many patients did you treat with DTR? Because I know you wrote some books. And how many volumes do you have now in your book?
Well, we have 9 volumes. This is the newest one.
I have that here.
It's probably backwards in the screen.
Yeah.
Right. This is the latest. This is volume 3 of a 4-volume set, which is about 3,000 pages on all we know about T-scan in dentistry. So it's T-scan in orthodontics, and T-scan in prosthodontics, T-scan in TMD, T-scan in Invisalign, T-scan general diagnosis, T-scan with implants, right? T-scan with crown and bridge, T-scan with posture. There's 26, chapters, patient education, doctor education. Anyways, to answer the question, I probably treated about 1,000 people throughout my years of traveling around the world, treating patients in live demonstrations, researching them at Tufts. I did all the foundation research on dental students from 1984 to 1998 when I was a crown and bridge instructor. So I used to carry around the T-scan 1, and it was a big thing, T-scan 1. It was like a big box, and I'd carry it around and I'd set it down in the operatory and measure dental students and study things. And finally, TechScan asked me to work with them to develop T-scan 2 and T-scan 3. So I stopped teaching at the school. And then I also, at the same time, had help from a number of interested dentists who wanted to study with me, the T-scan and DTR. But I would say overall, it probably totaled around 1,000 people.
I would think it'd have to be more than that, because
Well, I didn't practice a full
Oh,
week like, you guys
yeah,
might practice. And I was
yeah.
gone a lot to
Mm-hmm.
lecture and teach.
Mm-hmm.
So, and I really would only see 5 to 7 people a day in my office, sometimes only two. If I had a big reconstruction to do, I was one patient in the morning, one patient in the afternoon, sometimes only that patient all day long.
Wow.
So between the prosthodontics and the TMD, yeah, I would be guesstimating, but at least 1,000
Wow.
people, and many of them were study subjects and research subjects. Many,
Well,
many.
how many books have you written on T-scan, and like, are they for dentists or are they for patients?
So I've written, with the help of many authors, 9 research volumes. This is 2024, the one I showed you, but the first set was in 2015. That was 2 volumes, and then it was expanded to 3 volumes in
Mm-hmm.
2019. But a lot of research went on between 2019 and 2024, a lot of research involving the digital workflow and scanning technology and leaving impressions behind and moving into the digital world. And people were very confused about what T-scan meant and what scanning data looked like. So it was definitely necessary to update the
Sure.
research to include the digital workflow. And so, yeah, so it's 9
Wow.
books. The books would be 2, 5, 9, right? 9 books and over 100 peer-reviewed articles. And I've also ghostwritten a lot of things where a dentist would take the photos and do the data acquisition in their office for, let's say, a case report, but they weren't an author. So I would write it up for them and, make it all scientific, and then they would get their
Oh,
name on
wow.
it. So there's, yeah. And that was great because then they got recognition for, using these technologies. So, yeah, I've written a lot of things, no question.
So I've had you out to our office for the over the shoulder training, which was so eye-opening and really mind-blowing. And I gave a talk recently to local dentists in my area that focused on the T-scan. I just think every dentist needs to know this, whatever your dental training is. And you were so kind to share some of your slides with me that I presented. And I'm trying to tell these dentists, just because you get a big blue ink spot doesn't mean to adjust that spot first, or even that spot is necessary to adjust. So can you share a slide and show
Yeah.
how this is, like the different pressures points that can come from just something minor?
Yes.
Right.
Yes, I can show you a few examples. So just to give a little background, the concepts that dentists have been taught to adjust the bite, they're completely unfounded in science. And they've actually been disproved now, beginning in 2007. The first paper that disproved it was in 2007. This is a really good example of that, where there's these 3 large marks, which are sitting on healthy tooth structure. And then next to it is exposed dentin with no marks and lots of ink at the periphery. And then you see the counterpart 3 large marks sitting on very healthy tooth structure and no ink where there's destroyed tooth structure. And if this was really a problematic force, high force, the tooth structure would be injured here. But when you measure it with the T-scan, you find out the truth about what's really going on. And there's extreme force in this area. And there's no ink, right? And when there's low force, the ink survives. So the reason this happens is because the paper and ink can't survive this extreme pressure. So the dentin, if the enamel can't survive it, how can paper and ink survive it, right? So that's a really good example of how misunderstood the paper mark principles are. It's actually not true that the big marks are forceful and the little marks are light force. There's only a 14% correlation. And that means that big marks are forceful 14% of the time, little marks are forceful 14% of the time, and the other 86% of the time, there's no correlation. So when a dentist thinks they're choosing high force here, they're going to be wrong 86% of the time. And that's why people have so many occlusal problems. They grind the wrong places, and they don't no one in dentistry is facing this reality. When I'm lecturing, I ask the dentist which side has more force, and they're looking at the paper, right? And they're very, they think that this side has more force.
Right
So
away, you think that,
this
right?
picture. Yes, right away. But when you actually measure it with like I said,
Right.
high precision piezoelectric sensors, you find out that the right side has much more force. And it's actually twice as forceful, 67 to 32.
Wow.
Right?
Wow.
That was me
Right.
years ago,
Yeah.
because that's what I would have thought.
I mean,
Well, but that's what you were
Exactly.
taught
I
incorrectly.
feel like that's
Exactly.
still me right
Right.
now. Right? Like it's really hard to retrain your
To
brain.
unlearn. It is. And even when I go in there and I'm like, nope, Alex, do not take the big mark away. Like I have this little Robert on my shoulder, yapping in my ear. Get the T-skin. Don't do it. So that's what I do. But
Oh.
I get that. It's hard to unlearn everything that you've learned.
Oh, totally. Like, this was a really hard pill for me to swallow because I wasn't really taught that the bite.
Yes,
Yeah.
you would have been taught. You would have been taught that this side
Sure.
had more
Right.
force.
Yeah.
Right. And then think about what would happen. You'd go and adjust this trying to make less ink to match
Right.
up to this side. Right. And that would
Oh,
worsen the
totally
imbalance.
worsen the imbalance, right? If you're adjusting
Absolutely.
the wrong side.
Yes. And then there's another principle that's completely false, which is this is a really good example. This is a splint.
Right.
And people are taught in splints to make the paper marks the same size and make them, uniform, and you balance the bite. But again, when you measure it, you find out that that's not the case at all. The center of force goes left and it goes right. It's 10% imbalanced. And this patient said to the doctor, this was in a training, a T-scan training like you guys have been through. She said at the beginning, the splint is really awkward. And I know I've been back several times, it just doesn't feel right in my mouth. And then we were able to, of course, take this information. What you do with this information is you adjust where the ink marks show high force and moderate force, and you leave the low force ones alone, right? And then you re-record. And you guys know this from learning, but you're able to take, this kind of a splint, which doesn't really have balance, and create, with the T-scan, incredible balance. Watch what the center of force does. It comes right down the middle.
Amazing.
And there's total low forces around. And then if you look at the picture, compare the pictures, the paper marks are much bigger and they're not uniform, right? And this is the corrected
what
version,
works.
right?
Yeah.
That's what works. Yes. So the patient, she goes, in the middle of the process, because it took about 7 recordings, and of course, I'll just show the first one again, how the center of force doesn't go in the middle. And we were talking about the center of force, and she goes, does it ever go in the middle? Right? Because she was,
Sure.
aggravated that, she'd been back so many times. And then as we went through the process, and suddenly, it does obviously end up exactly in the middle. And she was like amazed that it could be done in one appointment and how much better it felt, right? She used the word awkward. So, this is a really huge problem in dentistry. And it actually,
yeah,
it's a huge problem.
Well, these slides are really telling, and you can't fake the pressure, with the sensor being as sensitive as it is. So when it comes to implants and the overloading of them, how would you measure a load without the T-scan and this technology?
Well, with the implants, you have a couple of different scenarios, so I can also show you that too. So you have two really distinct possibilities. You have a few implants between natural teeth, opposing natural teeth, and then you have lots of full arch implant cases where the big cases are. So, this is an example of that, right? You have lots of implants under here and crown and bridge opposing some natural teeth. And what you try to do with these kinds of situations is you try to level the forces in the same way. You use the data to guide, where it's too high and too forceful and too early, and you try and center the center of force. And you can do that very well, actually. You can get to an outcome which is, like this comparatively. Here's the pre-op one. And when you get done, if you'll notice, this looks just like the splint, right? The center of force comes down the middle. The forces are low, right? So you have this kind of control with the T-scan that you can do on almost anything you make, right? That's full arch. And this is a really great outcome for an implant case. There's no high forces anymore. The timing is great. The balance is great. When you have implants between teeth, like this situation, or near teeth, you not only have to control the closure, the up and down, but also the side to side. Because when you have implants opposing natural teeth, these implants can create muscle activity. They don't make muscle activity, but how they push on these teeth creates muscle activity. And we have a really good example of that. There was a dentist who came to a course many years ago, Dr. Reiter, and he had just finished having 2 implants made on his lower left, which is this picture you're seeing up here. And he was uncomfortable. And so we put him on the T-scan EMG, and you can see in the delivery, right, they totally left these implants in complete overload.
Look at that. Look at that pink.
Yeah.
Can you explain the pink
and the
to
orange,
our viewers?
The pink is extreme force. So the T-scan, it's actually right here. If you look right here, I'm pointing with the mouse. Low force is calibrated to be blues and dark blues, medium force greens, light greens, beginnings of high force, yellow, orange, and red. And then pink is the limit the sensor can reproduce for you. It can't, some pinks are very high force, even beyond, way beyond other pinks. But so what you try to do is exactly what this image shows with the T-scan is you want to have 1 or 2 pinks. So the rest of the arch is scaled correctly, right? So when someone has 10 pinks on the screen, if you ever go to a lecture and they show 10 pinks and they say, this is great T-scan data, they don't know what they're doing with the T-scan, right? So you'll see in all of these images, if you look back at some of the things I showed you, there's only 1 or 2 pinks because that's how you control the sensor to fit the patient's bite strength. So this was installed with a 76% to 22% imbalance, right? 20, right? And of course, the dentist didn't have the T-scan, right? So if you had this, you wouldn't let it go, right? You wouldn't let it go. You would adjust that. So we adjusted it in the course. And one of the things we found was when we were doing the pre-ops, not only was the closure off, but also the excursion. This is the excursion, and I'm going to show this to you in a second. This box shows the muscle activity of the excursion, and you can see there's all these spasms in here that the masseter and temporalis are experiencing because the implants are in the way of the movement. And you'll see the implants, the center of force goes right over the implants. The forces do drop, but they actually stop the patient from moving right there. They block the patient. So when we fixed, again, the disclusion time, here's actually a very short disclusion time. It's like 0.48, I think. When we fixed the disclusion time in the same patient, you can see all the spasms went away, right? And the disclusion time is now 12 hundredths of a second. So it got brought down, like 75%. And you see the corrected excursion and doesn't involve the implants. And the closure balance, look at the closure balance. The center of force is right in the middle again. So you can see how each of these situations, the outcomes can be very much the same, whether you're using implants, full arch, splints, full arch, natural teeth against implants. And you can see here the difference in the spasms that went on in the excursion, completely removed by the disclusion time reduction. So those are the two, kind of unique scenarios. So those all of these results, whether they're natural tooth occlusion or TMD patients or orthotics that you're making or splints that people make, which is another word for orthotic, and implants against natural teeth, crown and bridge, veneers, you can always control the outcome with the T-scan far better.
So are any dental schools teaching T-scan or DTR? Which my guess would be no, but you would know more than me.
Yes. Well, there are no dental schools in the United States teaching T-scan. Some have T-scan for research purposes, but the actual using it to do the things we're talking about, controlling outcomes in prosthetic dentistry or implant dentistry or treating occlusal problems, as you guys do in your offices every day, there's no school that's teaching that. And the sad part of that is they're all teaching the paper mark method that doesn't really work.
I guess, what is your thought on why this technology is not taught everywhere? Like when Dr. Alex told me about it, it was literally on a podcast and I hung up and I called T-scan and I was like, I want to order everything right now. And they were like, okay, who are you? What's going on? Right. So I got it right away and it's been amazing. And I'm really amazed to be able to help people with this minimally invasive procedure. So what do we have to do to like wake people up about this, whether it's like patients that are suffering or dentists?
Well, you guys are doing a great job waking patients up to the fact that there is, a real therapy for many of these problems that they face every day that traditional dentistry and traditional occlusion has not found solutions for. I mean, even splint therapy and orthotics and medications, they manage the patient to live better. And certainly in the compromised joint patients, they're very important, the orthotic and the splints, but they don't make up the masses. The masses are people going to the dentist to get crowns installed and to get implants installed and to get better dentures that are sitting on implants, and then the TMJ patients, they're part of the masses, and most of them are not joint compromised patients. They're headaches and facial pain, right? So you guys are bringing this to the public with your podcast and your efforts to reach them on your social media, which is a really great thing. But the dentists are not waking up. Dentistry does not want the T-scan to succeed for some reason and continuously spreads false information about it in classes. Like I have a very famous speaker who everyone believes knows a lot about occlusion telling his class that they shouldn't waste their money. I have a video of it. They shouldn't waste their money on a T-scan. All it does is show you a little bit of timing difference. You really don't need it, and you'd be better off buying a scanner. And that's
Will
on
you
video.
share the name with me
I don't
later?
show it very often.
Yeah.
I can share it with you later. But he's been discounting the T-scan. Someone might ask a question in a class. Oh, Dr. Expert, what about the T-scan? I saw it on Dr. Priya and Alex George's podcast, and I want to learn about it. And the lecturer will say, it doesn't work. The sensor is too thick, and don't waste your money, and just keep doing the paper mark guessing method. That's the essence of what they're teaching. And the reason they say those things is because there's this huge battle about who's supposed to be right about occlusion. And the resistance really stems from the fact that everybody wants their principles to be correct. And unfortunately for all of the principles, the T-scan has disproved all the philosophies. You can work in MIP. You don't have to move the mandible. You don't have to make an appliance or a deprogrammer. You can treat the teeth directly in the right patients. But again, the masses getting implants on the lower left, like we just saw Dr. Ryder's case, right?
Sure.
He's a regular person. He's going to get the implants, right? And he goes home and he can't wear them, right? I have to say, I'm amazed at how many phone calls I still get from people. The other day, the last 2 weeks, a phone number kept going off in my phone that I didn't have a contact. But it happened every 2 or 3 days, the same 646 number. So finally, after like 10 times, I figured I'd answer it because it was either a patient or a doctor who didn't want to tell me what was going on, right? So it's a patient who told me that he had 3 fillings changed about a month ago, and he went back to the dentist because his bite was thrown off, and he can't get comfortable, and he went to 2 other dentists. They tried to grind on the other side of the arch where the fillings weren't done, and now he has much worse pain. And all of it was created by guessing at the ink. Right?
14% accuracy, right? 14%.
Right. And the dentists, they don't know what they're looking at, right? And so the paper mark method is really dangerous for the public. So I think to answer your question, I think if the public knew that the dentists were really guessing, and which is what they do. The studies we've done and published show the dentists are guessing wrong 90% of the time. And they don't even realize they're doing it. So when I lecture, I say, like everyone looks at me like, yeah, we're not guessing, right? And I say, okay, what happens when you put in a single crown and the patient says it's high and you pick a mark to adjust and then the patient says it's still high? You guessed and picked the wrong place. And then I clarify that and say, now, if you'd picked the right place, maybe it wasn't completely adjusted. They might need a few adjustments to the crown, but they would say it got better. They would say, yeah, that's better, right? And of course, then everybody realizes. And then I say, so what do you do then after you miss the first contact? You remark and you guess at another one, right? So I think if the public knew the dentists were guessing, when they spend money on fancy implants and fancy veneers and smile designs, and Invisalign causes all kinds of occlusal problems. Right. And so the public isn't aware, and the dentists aren't being taught that this is bad for the public. It's a real health risk, actually. And it doesn't seem like it because it's a sort of an innocuous procedure, like you shave a little tooth structure. But you just said at the beginning, I believe, while I was in the waiting room, that someone had a tooth extracted and they developed a TMJ problem, or they began to have occlusal problems. That's one tooth was taken out, and then everything changes, right? And that's the problem, that when we change things, we don't actually know if we changed it for the better and how to correct that, right? And the paper mark method doesn't work, but the public doesn't know that.
Also, it's like
the public is completely unaware.
I think you coined this term, like dentistry's dirty little secret. Yeah, is that like our bite adjustments are only 14% accurate. And when we first spoke, I kind of shied away from saying that because I was like, I don't want to like make people upset. But I'm kind of at the point where I don't care anymore. So whatever. If people get upset, they get upset because
the truth is the truth.
Yeah.
The truth in his research and everything that was found.
Sure.
So, okay. Tell me more. Show me your research.
The research shows the percentage likelihood that someone can choose a contact is very low. Choose the correct contact is very low. But what it translates into is the dentist randomly grinding, thinking they're fixing things because they're taught that this is the way. And all the occlusal educators are teaching this. All the dental schools are teaching this worldwide. It's not just in the United States. It's taught everywhere instead of the truth coming out, right? And when dentists hear it, you just said it, Priya, they said they get mad. They don't want to face the truth about it, right? And I'm not sure why that barrier is there, because everyone really is supposed to be trying to advance the betterment of
the barrier is there because of ego. It's there because
of ego, and you only know what you know, and you don't stop to learn more things.
Yeah.
I mean, there's a whole reason why there's the barrier. Nobody wants to be proven wrong or said that dentistry's always done it this way, and now we're going to change.
Now we're going to change, but there's also the shame that comes along with, oh my God, I've been doing it this way.
We ruined so many patients in the process of not knowing. But you didn't know, so it's not your fault.
So it's not your fault.
But it is your fault when you hear something like this and you don't go out and you get more training. That's on you.
That's on you.
And there is better stuff out there.
And to just reject it based off of dogma or based off of history or based off of stupid reasons, right? Like, this is how it's always been done. Like, that's not good enough, right?
Right.
Well, that's what goes on. That's where the educator in front of the room says, no, don't waste your time with the T-scan. Don't spend the money. Doesn't work. Just keep doing the paper mark method. It's not in those words, but that's the essence of it, because no one who's not teaching T-scan guided occlusal adjusting, anyone who's not teaching that, the only way to do it is to guess at the paper marks. You can't adjust the bite with a scanner. You can't use scanning technology to adjust the bite. There's no forces in there. There's no timing in there, right? So all these educators are choosing not to face the truth. And the dental schools don't want to face the truth. And maybe it is ego, but for the patient well-being, it really has to change. I mean, you've probably heard me say, I don't know if it came up in our courses, but in a typical lecture, I would say, so is it okay for an eye surgeon to guess in your eye? Or a knee surgeon to guess in your knee, right? And of course, no dentist says, I want the guy guessing in my knee, so I won't be able to ski the rest of my life. I'm going to him so I can ski again, right? Of course, but dentistry has allowed this to go on and perpetuates it with the belief system that it works.
So what are the criteria that are needed in order to be a candidate for the T-scan?
You just need teeth. You don't even need teeth. You can have removable teeth. You just need to have occlusal surfaces that mill and mesh and bang into each other. And you can measure anybody, really. And you can determine, their balance, their timing, whether they have occlusal problems, why they have recession on two teeth, why there's exposed dentin, like in that case I showed with the paper marks, right? Why there's periodontal defects on only one tooth, right? And all the other teeth are really healthy. So the applications for the patients are dramatic. And anyone who has a bite can be measured.
But they can be measured, but can you adjust? Like, what I'm getting at is, like, if the joint is bad, you don't want to do a T-scan on them, right?
Yes. So treatment, you're talking about, can you take the information and treat? So they have to have healthy TMJs. which is obviously something that you can't tell without imaging or CBCT, and that's the standard of care in today's environment. To at least make a diagnosis in some way. I don't think panoramic X-ray is viable enough. It doesn't. You can see stuff, but it doesn't allow you to see the structures cleanly.
You would be shocked at the number of
Yeah,
panoramic
so-
X-rays I get in my DMs on Instagram and Facebook, and I'm like, I can't do much with this. Sorry. Well, I'm so glad you could join us today. If someone would like information about TEC scan or disclusion time reduction therapy, where should they look, or what should they Google, Doc?
I wanted to show you one thing that I'll answer the question. I'll come back to this. I want to show you something we've discovered recently. So,
Sure.
Both of you, Alex and Priya, you've both been to the digital occlusion seminar that we hold. Alex, yours was in Texas, but Priya, you were recently in the Las Vegas course. Now we mostly give it in Las Vegas because we're allowed to treat patients there, and
Love that.
Dr. Sutter has a license. But this is the next 2-day course, and the next one after that.
So this is in May,
and this is in May 16, 17. And so this is the way people learn didactically and can be exposed to all the benefits of learning to use the T-scan and the EMG to learn DTR. But it doesn't make them a clinician. And as you both know, and in this slide, you can see there's Dr. Alex. She's right there.
I made the slide.
Right?
Oh, I'm jealous.
Right. Yeah, everybody gets to see you, Alex. This slide is used in many lectures, right? The only thing I ever really changed is this picture. But this is an implant case. But if it wasn't, if I was, in an orthodontic office, not an orthodontic, if I was an ortho lecture, I'd put in like a perfect ortho case, up here, something like that. But you're in every picture. So this is the way people really learn. And I think you guys could attest to that. And I think it would be good if you commented about that as well before we get off the air. And then they can, of course, dentists can go to this website and use this discount code and purchase these 4 volumes for half off, essentially. So the thing I wanted to show you was one of the things we've recently discovered is that we can open the airway with DTR treatment. And if you look at this airway, it's kind of constricted, and this is the way the constrictions are colorized in a reconstruction. You get the green is like constricted area. And then after DTR, you see how bigger the airway is, and it grew a section, and all the constrictions went away, and it gained 50 millimeters of airway.
Can you explain how? Because for people that are lay people watching this, and even for me, this is like a hard concept to understand.
Well, in simple terms, someone asked me this yesterday when I was lecturing. So the DTR process resolves the muscle activity coming from the teeth, and it actually treats all the swallow muscle. So when you're swallowing, you have to close off your airway so food doesn't go down into your lungs, so you don't choke. So breathing, chewing, and swallowing is all modulated by tooth contact, and it all happens subconsciously without anybody really thinking about it. You're chewing along and you're breathing while you're at dinner, and you suddenly swallow, and then you take another bite of food, and all of that is controlled by the teeth rubbing together. So the muscles of swallowing involve a number of cranial nerves and the tooth nerves, and so when you do DTR, you actually relax the upper pharyngeal muscles, which is part of the upper airway, and the middle pharyngeal muscles, which is part of the airway. And so that's how it actually happens physiologically. Right? And just like you relax the temporalis and the masseter, right? You relax the upper pharyngeal muscles and the middle pharyngeal muscles. And that's because the glossopharyngeal nerve receives input from the teeth, and the glossopharyngeal nerve feeds the base of the tongue and the upper and middle pharynx. So it's a really powerful treatment. I used to hear from patients that they would come back after 1 or 2 DTR appointments, and they would tell me they were sleeping better. And this was before the era of sleep. And I would say to them, are you grinding your teeth less? And they go, yeah, I'm definitely grinding my teeth less, and I'm not wearing that night guard. I don't need that anymore, but I'm definitely sleeping deeper. And I really thought it was only due to the fact that they weren't grinding and clenching during the nighttime. But once we started seeing airway reconstructions and people doing DTR and seeing these volume increases in airway from the process, we realized that this is why that people are able to get more air, and they don't have to wear an appliance. And just the biggest difference about that, the last thing I'll say is when you use a snore guard, someone uses a snore guard, let's say, or a sleep appliance, it does open their airway on some level. But once they take it out, their airway goes back to exactly the same place. It's not physiologically changed. It's not like the snore guard made their airway volume increase permanently. Right. It only does it while the appliance is in their mouth. This is a permanent correction. And we have multiple cases of this now. So this is our new area of research.
That is. It's so nice to have you, and we appreciate you and the knowledge you're sharing here today, and for just being available for any of our questions we've had on cases. I know I've emailed you things and you've looked at scans for me, but we have a couple questions that we do from our listeners, and wanted to know if you'll help us answer them. Okay. This one's perfect for you. I've been doing research on tinnitus, and I came across DTR. Where do I find a doctor to see if I'm a candidate? Do you think it'll help my constant ear ringing?
That's a great question. Well, as you reported at the beginning, you've seen it improve ear ringing. So the reason DTR does that is the same as the throat pharyngeal swallowing. The ear muscles receive input from the teeth. That's why when you swallow, your ears open, like when you're on an airplane. And so what happens to the ear that gets, let's say, tinnitus or ear ringing, is that tympanic membrane, which is the structure that covers the eardrum, hyperfunctions. It becomes spastic. And that's where the noises come from. So it's the teeth are actually overworking it. And then you start to get noises that are there because of this spastic behavior. So absolutely, DTR can make a difference. The way you find someone is they should be a DTR trained clinician who uses the T-scan EMG and can find in your EMG data that is not ear data, but they can find in your muscle data that you are hyperfunctioning, very much like the first slide I showed with the extra EMG. If you have that in your masticatory muscles, your temple muscles, your cheek muscles, your ear function is also being hyperfunctioned. And so it's a marker. High muscle firing in the muscles of chewing is a marker for other areas being also hyperfunctioning, because the system works as one. Every time you bite down, every time you rub together, all these same muscles are hyperfunctioned. And so that's how you would find someone who could diagnose you. And the real problem is none of these things can the treatment provider say, if I do this, is going to cure your ear problem. You have to go through it. You have to be willing to go through the treatment and see how far your body will respond. And there is no real way to prognosticate with an absolute
certainty.
Right? And so you want the patient to realize that, because they're going to elect to go through it to have muscle relaxation, to have less headaches, to have less ear pain, but there's no way to predict. And the other side of that, which is why you really want to see a trained clinician, is that it has to be done well. Something that's lost on dentistry is occlusal adjustment is a very high precision procedure that controls the neurophysiology of the head and the neck and the ears and the throat and the airway. And if it's done cursorily, even if you own a T-scan, it doesn't mean you're going to get a good outcome. So the better you do as a clinician, the better the patient has a chance of healing to their most optimum. So there's no question seeing a DTR provider is a key to that.
Well,
I agree.
I agree too. But the interesting thing with tinnitus is my mentor would always treat with neuromuscular orthotics. And he would say tinnitus is like the joker in the deck. Like, we don't know if it's going to get better. We've never made it worse, but we don't know if it's going to stay the same. We just don't know. So I guess with DTR, with this type of therapy, like, what is your success rate with tinnitus, or what did you experience? Because to me, I still feel like it's sort of the joker in the deck, but I haven't treated a ton of patients who have tinnitus as their primary concern. I haven't treated them with DTR.
Well, there's a very high success rate in improving ear function when the tympanic membrane
Sure.
is compromised, because what happens is then it relaxes and becomes more normal. But there is a point where a spastic muscle doesn't recover completely because there's fibrosis, there's fiber damage, there's in other words, the toxic byproducts of muscle contraction have lived in this muscle for so long, it doesn't have the ability to return to spaghetti. It stays like steel wool. And this is the problem with someone who has tinnitus, because the tympanic membrane is a very small muscle. I mean, think how
Sure.
big your eardrum is. It's like smaller than
Yeah.
a dime, right? So the hyperfunction is, it goes on for years with these patients. I mean, every day they chew, eat, and swallow from the time they're teenagers, and they have a full dentition. They're hyperfunctioning that muscle. So the recovery is hard. So to answer your question, I would say conservatively 65 to 75% of the time the patients had a marked improvement in tinnitus, and they would have it here and there. And then the other 25 to 35% of the time, it wouldn't necessarily change dramatically. The intensity might be down, the frequency might be down, but the noises didn't go away. And this is the challenge, right? You don't know where you're interceding in the cycle of, fibrosis.
Sure. So another question is, how can I know what doctor to trust? I've been to a lot of different doctors and dentists, and they all have different answers.
Yes, it's difficult for the patient to, absorb all the different opinions. If they have not had their bite as a primary focus in their diagnosis, and I'm not talking about someone making models and making a night guard or an orthotic. I'm talking about the actual real bite mechanics, right? Exactly. And the disclusion, the occlusion and the disclusion, and the muscle physiology. If they haven't had those as the primary concern, they're probably not going to have a successful outcome, because those are the primary drivers of what is really going on with many, many, many patients, despite the opinions, because the dentists and the treatment providers are influenced by who they learn from. It's just like the paper mark problem. There's a whole continuum of doctors around the world, dentists around the world saying, the bite has nothing to do with any of this, and you're treating the occlusion as foolish, and you don't do it, So if they really want to seek out help, they have to see a trained clinician, T-scan trained, EMG trained, ETR provider, who can look at the occlusion intelligently and read the muscle physiology intelligently. And then the extended circumstances, for example, tinnitus or Meniere's disease, which is unilateral hearing loss, or trigeminal neuralgia, spark pain in the face. Those things respond to the treatment if the person has the occlusion muscle firing problem. If they have that, chances are pretty good they're going to get some kind of an improvement from a well-trained provider.
Well, thank you so much for being here with us today. We truly appreciate it.
My honor.
And best of everything. Keep writing away and keep teaching everybody. And hopefully we get the word out and some people come to your conference in Las Vegas in May and in September. And we'll make sure to add those links to this podcast too.
Yeah, we definitely will. And
well, thank you.
I'm just so grateful that I've learned all of this. So thank you so much. We really appreciate you.
Well, I'm grateful to both of you. And I think your willingness to learn it as fast as you did, Priya, shows that your mind is open. And that's really the thing. Dentists' minds are often not open because they get philosophized into believing whoever taught them is right. And unfortunately, around occlusion, if they're not measuring the bite with these technologies and the muscle physiology, they're not able to make intelligent diagnoses.
And I'm hopeful that I can get through to a lot of my colleagues that I went to dental school with. I was pretty well respected in dental school. And so I'm hopeful that as I learn more and as I do more, I can reach out to them and get them involved with this. I already have one dentist that's basically signed up for the course in May. So I just want to, expand that influence and go from there. But thank you so much. Thank you.
Thank you both. And I really appreciate the opportunity to be with you.